This is a presentation on control of ventilation. I'm going to use the usual approach that I take. I'm going to show content that I think that's likely to appear on the exam in red, content that I think is clinically relevant in blue, and content that I believe is both clinically relevant and likely to appear on the board exams in purple. The primary drivers of ventilation are carbon dioxide, oxygen, and pH. Obviously, it's possible to exert voluntary control over ventilation. You see that not only when a child says, "I'm going to hold my breath if you don't let me stay up later," but also you do it yourself when you take a deep breath when you're swimming. There's even a volitional element to breathing when we speak. Think about how effective would you be at communicating if every 5 seconds you had to stop to take a breath, even if you were in the middle of a sentence or a word. The rest of this presentation is going to focus on the automatic control of ventilation and how carbon dioxide, oxygen, and pH influence ventilation. The central chemoreceptors are located very close to the ventrolateral surface of the medulla. They are in an area known as the retrotrapezoid nucleus, and they are glutamatergic. They connect to what's called a central pattern generator for respiration. Unlike the heart, which has a single group of neurons that establish a cardiac rate and rhythm, the respiratory system relies on several groups of distinct neurons to establish and maintain ventilation. This slide shows the 6 groups of neurons involved in normal ventilation: the early inspiratory neurons, the inspiratory augmenting group, the late inspiratory group, the expiratory decrementing group, the expiratory augmenting group, and the late expiratory or pre-inspiratory group. It also shows how they fire, how each group fires, and the muscular activity that's associated with each one. It's not important that you know that or that you remember that. I just included it for the sake of completeness. The central chemoreceptors respond to changes in CSF pH. The blood-brain barrier is generally impermeable to both hydrogen ion and bicarbonate, but it is permeable to carbon dioxide. So what happens is that the carbon dioxide diffuses through the blood-brain barrier into the CSF, it's hydrated to form carbonic acid, and then the hydrogen ion from the carbonic acid acts on the central chemoreceptors. The increase in CO2 produces an increase in hydrogen ion concentration, which then produces an increase in ventilation. It's important to know, and a potential subject of a question, that the partial pressure of carbon dioxide in the extracellular fluid, the CSF, the cerebral tissue, and the jugular vein are all about 10 millimeters of mercury higher than the arterial PCO2. As you might imagine, since you're having to go to the brainstem to affect this, and since the CO2 has to diffuse in and go through this whole process, the central chemoreceptors are not a very rapid responding system. They're actually perceived to be more of a steady-state monitor of carbon dioxide as well as tissue perfusion. In reality, about 80% of the total ventilatory response to an acute change in PCO2 is mediated by the peripheral, not the central, chemoreceptors. Over the course of several hours, however, if the altered PCO2 is sustained, changes in CSF bicarbonate concentration will occur. These changes effectively result in the altered PCO2 becoming the new normal. I saw that clinical significance of that when we would hyperventilate a child for increased intracranial pressure. That used to be the preferred mechanism, the preferred treatment for patients with intracranial hypertension. So the deal was that the conventional teaching was that you would not get any further decrease in intracranial pressure once you got your PCO2 to be about 28 millimeters of mercury. Well, the interesting thing was that I would have patients with Reye's syndrome who I would initially ventilate to an arterial CO2 of about 32 and then on down to 28. And after a day or two at 28, the conventional thinking would have been that you would not get any further decrease in intracranial pressure by hyperventilating below that. In reality, however, after a day or two at 28, I could then come in and decrease the PCO2 even further down into the lower 20s and get a further decrease in intracranial pressure. That's obviously not advocated now. The concern is that the cerebral vasoconstriction occurring with that degree of hyperventilation compromises cerebral blood flow. That's not really the point. I'm not advocating that treatment intervention. I'm simply trying to demonstrate to you that this phenomenon of a bicarbonate shift does occur and has clinical applicability. The same phenomenon, that is a shift in the CSF bicarbonate concentration, occurs whether the disturbance is respiratory or metabolic, and it doesn't matter whether it's acidosis or alkalosis. So then, as we said, the central chemoreceptors respond to a decrease in CSF pH, and the PCO2 in the CSF is about 10 millimeters of mercury higher than the arterial CO2. The central chemoreceptors are responsible for only about 80% of the ventilatory response to an acute change in CO2, and over time a shift in CSF bicarbonate concentration occurs. So let's talk about peripheral chemoreceptors. The carotid bodies are located at the bifurcation of the carotid artery. They respond to hypoxia, hypercarbia, acidosis, hyperthermia, and hypoperfusion. The carotid bodies are relatively hyperperfused. Blood flow is about 10 times normal based on their size and their metabolic rate. This results in a very small difference between the partial pressure of oxygen in the arterial and venous blood. The response time of the carotid bodies is very quick. An increase in discharge rate of the afferent nerves of the carotid body is detectable within 1 to 3 seconds after the onset of a decrease in the partial pressure of oxygen in arterial blood. Given the location of the carotid bodies, it's not surprising that the carotid bodies may be lost or are commonly lost with carotid endarterectomy. We'll talk about the relevance of that later. So the first stimulus that people think about when they think about the peripheral chemoreceptors is hypoxia. It's important to note that this response is triggered by a decrease in the arterial PO2. It's not stimulated by a decrease in arterial oxygen content, as would occur with anemia, nor is it influenced by aberrant forms of hemoglobin, such as with carbon monoxide poisoning, carboxyhemoglobin. Although the arterial oxygen content is dramatically reduced, it doesn't have any influence on the arterial PO2. It's also increased by, or the peripheral chemoreceptors respond with increased ventilation to an increase in hydrogen ion concentration. It doesn't matter whether the acidosis is metabolic or respiratory. It is not a strictly speaking linear response. There's a threshold of acidosis which has to be achieved before you get an increase in ventilation stimulated by the peripheral chemoreceptors. They also respond to decreased perfusion. So a patient who's hypotensive due to decreased perfusion may have an increase in minute ventilation. The presumed mechanism for that is what people now call stagnant hypoxia. Again, if you think about it from the perspective of it's sensitive to some degree, the difference in partial pressure between the arterial and mixed venous blood, or the arterial blood and the venous blood in the peripheral chemoreceptors, if blood flow is decreased, then you would expect there to be an increased difference and you would get an increase in ventilation. The peripheral chemoreceptors also respond to an increase in temperature, and to an increase in the partial pressure of carbon dioxide in arterial blood. The significance of the carotid endarterectomy and the location of the carotid body is that, as we'll see in a few minutes, you get a decreased ventilatory response to hypoxemia following carotid endarterectomy. This graph shows the oxygen respiratory response curve. You'll notice that the minute ventilation increases initially for about 10 minutes after the onset of hypoxemia. But then there's a gradual decrease that lasts for about 20 to 30 minutes more. It's still above baseline, since this is the baseline value, but it's less than it was earlier. After that period, then there's a gradual increase in ventilation for at least 8 hours. Hypoxia causes decreased central respiratory neuronal activity, producing apnea in patients who have denervated peripheral chemoreceptors. That would be the patients who have a carotid endarterectomy. It's also relevant in neonates. If you think about that, if you make a baby hypoxic, if you make a baby hypoxic, not hyperoxic, but hypoxic, they may respond to that with apnea as opposed to an increase in minute ventilation. This response is more of a problem, or is more noticeable in premature neonates. This slide shows the ventilatory response to progressive hypoxemia. The solid line is supposed to denote the normal, okay? And that represents what happens when the PCO2 is maintained at a constant value. So what you see is that initially there's not much of an increase in ventilation until the arterial PO2 is probably somewhere in the vicinity of 90 or 100. But in reality, while that may be what happens in the presence of maintaining the PCO2 normal, what actually happens in patients is along this line, because this represents what happens because as they increase their minute ventilation, you'll see that there's a gradual upward slope here. As they increase their minute ventilation in response to hypoxemia, then they become hypocarbic. The hypocarbia then causes ventilation to decrease. So there is a difference between what you see in the patient in a clinical situation and what you see in a subject under artificial conditions where you maintain the PCO2 normal. This curve then represents what happens in the presence of hypercapnia or exercise. And as you'd expect then, at any given value for PO2, the minute ventilation is higher in the hypercarbic patient than in the patient who is not hypercarbic. The CO2 response curve is a subject that's ripe with a lot of questions for the exam. And it also tells us a fair amount about what we want to know clinically in terms of the patient. This diagram shows the CO2 response curves in different conditions, but I want to look at it in a bit more detail. Unfortunately, this is going to re-emphasize the fact that I'm not an artist, and I apologize in advance. The first thing to look at here is the red dotted line. This represents the PCO2 occurring as a result of a specific minute ventilation without any inspired CO2. So, as this would basically be what you would see under normal circumstances, and you'll see then that the PCO2 is 40, and unfortunately I didn't label this y-axis, but it's about 8 liters per minute, which would then represent a tidal volume of about 500 milliliters with a respiratory rate of about 16, pretty close to normal. As the subjects release inspired CO2, minute ventilation increases. Okay, well, that makes sense. The patient's becoming hypercarbic. The partial pressure of carbon dioxide is going up. There's going to be an increase in minute ventilation. They have to have an increase in CO2, because if they ever ventilated back down to the normal value, then the stimulus for increased ventilation would disappear and the PCO2 would increase again. Okay? The horizontal line at the next thing, so the second thing that we're looking at here is the slope of this line. The third thing to look at is where this line intersects the dotted line for baseline. It shows that even as the arterial CO2 goes below 40, patients tend to maintain a relatively normal minute ventilation. That's not true in all patients, but it's what happens in most patients. This graph shows the same curve with the line extrapolated back down to a point of zero ventilation. That is, if the PCO2 is below the value where the line intersects the x-axis at that point, then the patient will become apneic. This value then is known as the apneic threshold. It's about 5 millimeters of mercury less than the resting PCO2. And if you'll notice, this line of the essentially normal or not only slightly reduced minute ventilation persists until you get to the apneic threshold. Notice that the CO2 response curve is only represented up to a PCO2 of somewhere in the vicinity of 50 or 60. At some point, hypercarbia actually becomes a respiratory depressant. In normal conscious subjects, respiratory depression occurs somewhere in the vicinity of an arterial PCO2 of 100 to 200 millimeters of mercury. In patients in the recovery room who have residual anesthetic on board, it's likely that the respiratory depression occurs at a much lower value. One other thing to notice about the CO2 response curve is that it's linear, at least over the values that we're showing. Because the CO2 response curve is linear, it can be described by the slope of the line, and the intercept with the x-axis, the apneic threshold. So people have developed a formula for that, and it's shown there. The normal values for this appear over here. Now let's look at this for just a minute. So if we come back up here and you say, okay, the formula is S ventilation, minute ventilation, equals the slope times the PCO2 minus the apneic threshold. And so then let's put some normal values in here. The slope is 2, the normal PCO2 is 40, the normal apneic threshold is about 36, so then the minute ventilation is 2 times 4, which equals 8 liters per minute, which is the normal minute ventilation. So the graph makes sense, the formula makes sense. This is a CO2 response curve with a second line shown in black superimposed. This is the CO2 response curve that occurs in the presence of an increased PO2. It's generated by having the subjects breathe 100% oxygen. It's presented here just to demonstrate that hyperoxia does actually blunt the CO2 response curve. Notice that it changes the slope of the curve, but not the intercept with the x-axis, the apneic threshold. It does, however, produce a slight increase in the resting value for the partial pressure of carbon dioxide in arterial blood. The third curve represents the CO2 response curve in the presence of hypoxemia. Note that although the apneic threshold isn't changed, again, both the slope of the line and the value for the resting PCO2 are altered. This illustration shows how the CO2 response curve is altered by the presence of a metabolic acidosis. The fan shows the same three conditions. The line in the middle is normal. The line to the right is under conditions of hyperoxia, and the line to the left is with hyperoxia. So normal, increased O2, decreased O2. Now think about what you'd expect under the circumstances of a metabolic acidosis. And forget the lines with the hyperoxia and the hypoxia. Just look at the middle line here. The first thing that you expect is the patient will be hyperventilating. Well, in fact, that's reflected by the fact that the intersection of the middle line with the red dotted line represents a lower value for the resting arterial CO2. The second thing that would be that the apneic threshold would also be lower. Well, that makes sense, right? Now you might have to think a little bit about the slope of the line in order to understand the fact that the slope of the line is less. The line itself is flatter. But if you consider the fact that the metabolic acidosis already is stimulating an increase in minute ventilation through other mechanisms, then it makes sense that the slope of the line might be a little bit less with an acidosis. So here's the curve with each line labeled and with the apneic threshold indicated. So again, when you look at the CO2 response curve, you want to pay attention to a couple things. You want to see the apneic threshold. You want to look at where the resting PCO2 is. You want to think about the factors that are going to affect the slope of the line and that will affect the apneic threshold. So I'd like to summarize this presentation then in about 3 slides. The first one is the central chemoreceptors. They respond to changes in hydrogen ion concentration created primarily by changes in the PCO2, and this should be labeled as CSF hydrogen ion concentration. The blood-brain barrier is impermeable to carbon dioxide. The blood-brain barrier is permeable to carbon dioxide, but not to hydrogen ion or to bicarbonate. Over time, the value of PCO2 becomes established as the new normal. With regard to peripheral chemoreceptors, remember that they respond not only to a decrease in the partial pressure of oxygen in arterial blood, but also to hypercarbia, hyperthermia, acidosis, and decreased perfusion. Remember also that the loss of peripheral chemoreceptors, such as occurs during carotid endarterectomy, can alter a ventilatory response. Finally, think about the CO2 response curve. Remember that it's described by the slope and the intersection with the x-axis, the apneic threshold, that the CO2 response curve illustrates the normal value for the resting partial pressure of carbon dioxide in arterial blood, and that's shifted by acidosis, alkalosis, hypoxia, hyperoxia, and respiratory depressants. It may also be altered by respiratory stimulants. Thank you very much for your attention.